Good afternoon again, everyone. Welcome to the CHEST COVID-19 webinar series for Tuesday, December 17th. I'm Steve Simpson. I'm your fortunate moderator for the day and also the president of CHEST for 2020 through 2021. I hope that you've been listening the last couple of weeks to our series that we put together to close out the year. The entire series is or will be available for viewing and listening pleasure on the CHEST website, where you've grown accustomed to go for these webinars. The title of the series is Hindsight is 2020, and thankfully it is hindsight, a lot of it now, what we've learned about COVID-19. Parts 1 and 2 were about systems of care during COVID-19, what we've learned there, what we've learned about bedside care in COVID-19. And today we're going to tackle some really thorny issues about what we've learned about ethics, research, and communication during this time of COVID-19, which has been a challenge for all of those things. We have an excellent and expert panel lined up for you today. And I will just point and you guys can wave, and then I'm going to let them give their detailed introductions here in a moment. We have Nick Bosch with us from Boston. We have John Icarino, and we have Deborah De Bruin. John, why don't you start by introducing yourself first?
Sure, thanks, Steve. I'm John Icarino. I'm the Director of Guidelines and Statements at CHEST. I'm also a pulmonary critical care physician on faculty at Boston University.
Mm-hmm. And Deborah, please.
Hi, everybody. My name is Deborah De Bruin. I am the interim director of the Center for Bioethics at the University of Minnesota and the co-lead of a statewide ethics group in Minnesota called the Minnesota COVID Ethics Collaborative.
Mm-hmm. And Nick.
Hi, I'm Nick Bosch. I'm an assistant professor of medicine at Boston University, like John, and I am the principal investigator of a multi-center trial studying awake-prone positioning in COVID.
Fantastic. And so today, all of our presenters have a few slides to show you. I know if you have watched our webinars before that we don't always have slides. Sometimes we do, and today is one of those days. So I believe our lead-off speaker today is John. John, take it away.
Yeah, sure. So I'll start by my disclosure. I don't really have any disclosures except for the fact that I am at CHEST as the Director of Guidelines and going to be speaking about guideline development. And so, really, I'm hoping to take just a few minutes and leave some time for questions and discussions. But really, my little talk is going to focus on how guideline development changes when you're faced with a pandemic. And really, there's a few major changes. One is that things have to happen quicker than we're used to with guideline development. And two, things have to happen with a lot less evidence. So, evidence-based guidelines are predicated on good evidence. And so how do we make good guidelines when we don't have that evidence, but physicians and patients need guidance? And so normally, the normal guideline process, for better or for worse, takes about 12 to 24 months and usually closer to the 18 to 24 month time frame. We're always trying to make that shorter, but that ends up being about the shortest we can produce guidelines on a regular basis with our normal level of resources. When you have a pandemic like COVID-19, the timeline shrinks significantly to a matter of months, sometimes weeks, and in some cases even hours when very emergent guidelines are needed. And whether providers should wear N95 masks is a great example. That's a case where very emergent guidance is needed, and you can't take weeks or months to produce a recommendation. And so at CHEST, our normal guideline process, we use what's called the GRADE process. And GRADE is a systematic way to produce guidelines where there's many steps involved, but the general gist is we start with empaneling an expert panel with multiple stakeholders. We go through conflict of interest, a very important step to assure that any recommendations we produce are free from intentional or unintentional bias. And then we go through the actual development of the guideline itself. We develop questions, We search the literature through multiple databases, develop meta-analyses, systematic reviews, and that leads us to evidence profile that we can then use to inform recommendations based on those original questions. Ultimately, that gets then published in the journal and then disseminated through the audience that we're targeting. And so how do we do this when, again, we have to shrink the timeline? Well, naturally, we have to cut out certain steps. And so really it's weighing what do you need for develop recommendations and what do you want? And really trying to parse out what's the want and what's the need, because we really have to focus on what we need. And so here at Chest, that we've done that actually through multiple iterations. We've kind of learned as we went in terms of what parts is it okay to cut out? And honestly, probably some of the parts we cut out at the beginning, we probably shouldn't have. And so those are some of the things we've learned along the way. But it also kind of, I think, brings to the forefront, well, what are guideline recommendations and what evidence are they based on? So normally good evidence-based guidelines are based on systematic reviews of randomized controlled trials. Oh, great, we have some slides. You can go probably all the way ahead till you see the rainbow pyramid. And so systematic reviews based on good randomized controlled trials, this is our normal hope with a guideline. And sometimes we look at cohort studies, sometimes case control, but rarely, if ever, do we look at case series, case reports, or use just clinical experience to make a guideline recommendation. But if you move forward about 3 or 4 slides, you'll see slowly we start to lose these levels of evidence when we're talking about COVID-19. So if you go ahead one more, this is really where we were at particularly at the beginning of the pandemic. We really just had people's experience, maybe some case series, case reports, which have carried very high risk of bias and very low reliability. But at the same time, these are questions that clinicians need guidance on. So you can't just say, there's not enough evidence, we can't make a recommendation, because a recommendation is really needed. Next slide. It also brings to the forefront what goes into a recommendation. It's not just the quality of the evidence or the balance of desirables and undesirables. It's also patient values and preferences, resource use, equity, acceptability, feasibility, all important factors, particularly with something like COVID-19, an emerging new disease that we have to factor in when we're thinking about recommendations that have very poor evidence to begin with. Next slide. But what else can we use? Well, we can use indirect data. And this there's a lot of pros and cons of indirect data. And with COVID-19, we had SARS, MERS, H1N1, and other respiratory viruses that from prior years that we could at least look to say, well, how did that behave? How did that affect the healthcare questions we're looking at? The Ebola virus, just as a epidemic, pandemic nature, when we're thinking about system level questions. So how can we use these other diseases to inform our healthcare questions? Certainly that's helpful and invaluable when you just don't know anything at the beginning. And maybe there's good studies in these other diseases, but you have to be very careful because it's not the same, right? There are inherently differences. And so when you're forming recommendations for a different disease, for this disease, you have to be open to the fact that that's going to change as we learn more and that you need to update those as we learn more about the disease. Next slide. And so really, I put together kind of a top 10 list of the lessons we have learned and kind of what really kind of came out through our a little bit of trial and error as we developed guidelines through this process. So first, you'll see how topics are selected and prioritized. And really what this is getting at is, there's, I think, a instinct to just say, well, these are the guidelines we've already produced. Let's just produce them again and just add COVID-19 to the end of the title. But really focusing on, well, what do patients need? What do providers need guidance in? But also, what is everyone else publishing? What is everyone else doing? And let's not repeat that. We don't need 3-4 societies all saying the same thing, or even worse, maybe saying different things. How can we partner with other societies so that we have a single voice and actually help providers and help patients? When we're forming panels, how do we ensure that all necessary stakeholders are? This is important with any guideline, but with something like COVID-19, where it's really multidisciplinary through a lot of the steps with infectious disease and how it affects other specialties. Surgeons are affected, All specialties are affected. And how do we get everyone's voice on the panel? Conflict of interest was a huge one. So this is something CHESS is very dedicated to. But early on, we were very conflicted. How do you do this quickly? Conflict of interest assessment at CHESS in the past has taken us weeks. And so how do you do that when you need guidance within weeks? And so how, developing a rapid conflict of interest policy, because this is incredibly important, particularly when there's poor evidence. Because in that case, the experts are really relying on their own experience, their own knowledge, much more than the evidence for these documents. Making sure you know who your audience is. So we've seen guidelines come out from the CDC, the NIH, and many other organizations, but are they aimed at patients? Are they aimed at providers, policymakers, hospitals? And knowing kind of who your audience is can really help guide you through from the very beginning as you develop your panel through the end about what the recommendations and their implications. Number 5 is probably the most important one. The one thing we learned is that no matter what you do, it's incredibly important to be transparent and consistent. Whatever decisions you make along the way, just being very clear about what you did and why. And that I think helps your readers, helps your audience understand the limitations in your guidelines, knowing that, hey, this is based on very poor evidence. It's subject to change. It's a recommendation, but it's a very weak one based on low quality evidence and what that means. Next slide. And so just to kind of finish things up here, how do we balance this low quality with clinician experience? How much value do we put on clinician experience? You'll often hear clinician expert opinion. I don't like that term because we all have opinions, which often is based on evidence. And so expert opinion, I think, has a pretty negative connotation because experience is important, right? Expert experience and clinician experience and what people, sometimes that's all we have, which actually is what happened early on in COVID-19. We talked a little bit about indirect data, but jumping to number 8, again, how are we updating these guidelines? A lot of our documents that we produced in COVID-19 were in the early summer when we didn't know a lot. Now we know more. We've done, there've been some studies, there's been some additional literature, and we're in the process of updating those recommendations because some are already outdated, just 8-9 months into the pandemic. And this is different. Usually in our normal guidelines, we're updating every 4 or 5 years, and now we're updating every 6 to 8 months. And then the final 2, how are we assuring this gets out to the people it needs to, gets out to clinicians, and actually gets to the bedside? And so we've taken a lot of steps that we initially don't do with our guidelines, but now actually are using for our regular guideline process, partnering with other organizations, both at the national level and the local level to assure that our guidelines are seen, they're visible, and that they're usable, that they're able to be implemented, which is incredibly important to it, assuring they have effectiveness with patients. Next slide. And so that's really, I think the gist of how things have changed rapidly with guideline development, some of the issues we faced. And so I'd love to hear any questions or points for discussion from anyone.
John, I think Nick has a question.
Sure.
Thanks, John. That was fantastic. And my question was, you mentioned how is COVID different versus the same? We have this literature from other diseases and more general supportive care management. And so my question is, how do you balance maybe less robust data, but COVID specific, and more robust data that maybe only partially applies?
Yeah, that's a great question. And that's something we face a lot in terms of saying, which is more reliable? Would you rather an RCT and H1N1 or a very small cohort study in COVID-19? There's not really a straight answer. A lot of it has to do with the studies themselves and about, the population and sort of, the risk of bias that goes into each. Sometimes you would weigh one more than the other, and sometimes you might not. It also probably depends on how much indirectness you think there is. So, H1N1 is probably a great example. There's probably a little bit of a similarity, but it's a very different virus. It's a very different disease. SARS-CoV-1, maybe you say, well, there's actually maybe a lot of similarities. Maybe we think that they're much more similar than H1N1. So if there's a good RCT there, maybe that's a little bit more believable than an RCT with H1N1. So I think it kind of depends on the degree of indirectness, which really there's not a great way to measure, as well as the quality of your small COVID-19 studies or low quality COVID-19 studies.
Kind of makes me think that there's an opportunity for a third grading system. I mean, there's grading of the evidence, but also how related it is to the disease you're dealing with.
Yeah,
so that actually comes in as we do make recommendations. Indirectness does actually get applied to whether you upgrade or downgrade your overall quality. But it is a sort of a different part of the process. So you're right, there probably is a different way to assess it earlier on.
I'm going to take care of a little bit of housekeeping now that I forgot at the first, which is for those of you in the audience, if you have questions, please type them either into the chat or into the Q&A box that you see at the bottom of your Zoom screen. We are going to have each person's going to give a little talk, and then we'll have a free-for-all discussion here in a little bit, and we'll get to as many questions as we can. So John talked about how to balance where we don't have information, and Nick Bosch, who is next. For those of you who are late, this is Dr. Nick Bosch, who's an assistant professor at Boston University, and he took a very solid approach to helping to create that balance, or to overbalance in one direction or another. I guess, Nick, you will tell us that. And you look to be still muted before you start. So go ahead and take it away.
Thanks, Steve. Yeah, so the topic of conducting research during COVID is, of course, huge. And so this is just a word cloud for things that came to my mind when talking about research during COVID. And I think we've all feel, a little uncomfortable because it's affected our research in many ways, about ongoing research and pauses in research, funding. I think we could talk about many things today, and I hope we can talk about that in the panelist discussion. But I'm going to try to limit my talk to a short talk about our experiences with doing a multi-center trial here during COVID. So next slide. I have nothing to disclose about this presentation other than being the principal investigator for this study. So early on in the pandemic, at least in Boston in April, we were having a huge surge in the virus. Everyone was working all the time in the clinical realm, and we were all doing, quote, everything possible to try to help our patients. And John and I both work at the same hospital, and we work in a safety net hospital, a large safety net hospital in New England. And I think there was a general feeling that our patients did not, or potentially could not, have access to the same multi-center trials that other hospitals do. And there was concern that then patients at our hospital weren't going to be receiving the same potentially life-saving treatments that other patients might have access to. And so early on in the pandemic, there was, I think many of you probably feel the same way. There was a push to give some of these medications and treatments that weren't necessarily based on the most robust evidence. Hydroxychloroquine comes to mind, but there's a lot of other medications, cytokine inhibitors and others. And so based on that, we thought that we were doing right by giving the opportunity for our patients, maybe some justice and having access to these medications that we were excited about and thought that could help to save lives. And I think soon thereafter, we kind of realized the opposite, that rather than giving opportunities to our patients to try these medications that are, I think, really just unknown in terms of their evidence for whether or not there's a benefit, we decided that a better way to approach this was to study these treatments and medications. And I'll start off just by showing this quote from Singer in the Red Journal. And I think it speaks to me and a lot of us who do research with patients who have COVID about the importance of doing research rather than just trying something. So the takeaway here is if we just try things on our patients, we ruin clinical equipoise, we ruin usual care, and we miss out on an opportunity to find out if something works. And in addition, human beings have this amazing ability to attribute cause and effect, but we're less good at detecting harm when we do things. And so the point here is that we have to make sure that we are giving access to patients equally to research so that we can help answer some of these questions rather than assuming we know best. Next slide. So for us, that meant prone positioning. So prone positioning in April and May came out hyped strongly. It was in NEJM Journal Watch. It was in CNN Health about this life-saving therapy. And it turns out that prone positioning, you can see in the lower right-hand screen here, prone positioning at higher P to F ratio, so all the way on the right-hand side of the graph, actually has a trend towards harm in these patients. And so just, this is in mechanically ventilated literature, not in awake patients. But the point here is that we were concerned that prone positioning would go the way of hydroxychloroquine or other treatments, that it would become standard of care despite not having a robust evidence basis for using it, and that potentially it could be harming our patients. And so that was kind of the Boston University side of things. And I'll go ahead and say next slide. But it turns out that there were a lot of like-minded people across the US. So thanks to Steve Simpson, actually, he tweeted out, I think, a really important tweet for us in May, looking for other like-minded people who wanted to study prone positioning. So this was we started a multi-center trial that began out of Twitter. And so what we did is we formed a consortium of investigators. These were all investigator-initiated ideas to form a pragmatic, adaptive, multi-center trial. And we started off with 2 sites, Kansas and Boston, and we've grown to 11 sites across the world. And what we're doing is we're making a self-prone positioning recommendation on patients' cell phones to look at reducing rates of respiratory deterioration and ICU transfer in patients who are hospitalized with COVID-19 but not yet mechanically ventilated. And everything's remote, and right now we have sites in the US and Spain. So next slide. So rather than focusing on all of the ins and outs of the trials, I'd just like to talk about a couple of things that we came across that were unique to COVID-19, barriers that we had to overcome in conducting research in COVID-19, and then also some of the lessons we've learned. And so the first is this idea about shifting standards of care and equipoise, which I already mentioned. However, there's 2 parts of this. One is identifying a population of patients who you think will benefit from a study intervention, but not so much that they would benefit that it would become standard of care. And then second, things are changing so fast with COVID-19, especially things like dexamethasone, new medications we're realizing are effective. We have to adapt to that in our trials to make sure that the effect that we're seeing in our trials is due to what we're studying and not all of this other changing care. So it makes for a complex analysis during these trials. So for this shifting standard of care, we found it was really important to engage our clinicians early, trying to identify with them who were patients that might benefit from a therapy, and also patients that wouldn't automatically receive this care therapy. So for example, for us, it was trying to decide what's the oxygen level at which clinicians say this patient's going to be prone no matter what you say, versus those patients who are maybe on no oxygen and would have potentially no benefit from prone positioning. The next hurdle was resource utilization. The resource utilization can refer to research assistants. It can refer to PPE. It can refer to the nurses who are taking care of these patients and so busy they don't have the time to do anything other than clinical care. And so in designing a clinical trial for COVID-19, we wanted to ensure that everything was remote. That means consenting patients over the phone as much as possible, an intervention that's also remote, and then also data collection that's pragmatic, based purely on EMR outcomes, so we don't have to really talk to the patient at all, or collect blood or otherwise use those resources. And then taking advantage of researchers who had their research paused, especially early in the pandemic. We'll talk about how that's changed since. But a lot of researchers who had their research pause were available to help us with the trial early on. Next, limited subjects, lots of trials. Everyone wants to to help these patients. Everybody wants to do COVID research. And this means that patients are often, at least at our hospital, being approached for 3 or 4 studies at times. And so navigating this complex process of deciding which patients are right for certain studies, also which patients the risk-benefit ratio makes sense to enroll a certain patient. So I think this is not unique to our institution, but having a research oversight committee that helps to navigate these different trials and trying to reach out to hospitalized patients is an absolute must. The short timeline of COVID-19, we all are hoping that this will be a pandemic that maybe ends in 2021. And so coming up with unique ways to conduct research quickly, but also safely in these patients is important. For us, that meant having an adaptive randomization. So having a randomization sequence that changes based on the level of benefit in both arms. So in that fashion, you're both identifying the effectiveness of the intervention and also implementing at the same time. So once the study's done, you're ready to roll out to patients. And then also for us as a non-FDA study, because we're not studying a medication, being able to use a common protocol, but separate IRB approvals at individual sites was something I think that was unique and helped us to get rolling quickly. And then lastly, the surge has varied by geographic regions. And so a huge part of this, and especially with Steve's help, has been identifying sites before a surge hits. And I think this is also something that the vaccine trials have recently done well, is having patients who are having sites who are ready to start enrolling when a surge hits. And we've seen that with our study where we've had multiple sites go through lulls in enrollment and also very fast enrollment depending on where the surge is. All right, next slide. I think that's my last one. So in conducting our study, we've learned a lot. And so one of them is COVID burden. We've all experienced the fatigue associated with COVID-19. We've seen our volunteers go back to their own research. We've seen them be less interested in continuing the study. So there's been a lot of cheerleading that's been involved in conducting COVID research to try to get it to continue. There's been some sites who have had to cease completely because they can't afford to have their clinicians doing anything other than clinical care because they've been overwhelmed. We've had to reevaluate the risk-benefit ratio of our intervention based on emerging evidence and emerging guidelines. And then, then that means frequent protocol amendments in order to try to adapt to these changing guidelines, these changing medications. I've talked about organizing sites prior to surge. And then, at least for our study, I think the side effect of implementing an all remote study has been that there are potential issues with research justice. So not everyone has access to a smartphone to get a recommendation to prone in the hospital. And so coming up with ideas to overcome some of those potential issues with inequities around donations or other technology that the hospital already has been key to success. And then lastly, I'll just say that early collaboration has made a huge difference in conducting this study, making sure you're engaging the stakeholders for an investigator-initiated protocol, especially making sure that everyone has their say in helping the study proceed, and then reaching out to other studies doing the same thing for meta-analyses after your research is complete. Next slide. So that's it. There's a couple people I'd like to thank. The study's ongoing, and I think there's a lot more to talk about with research during COVID. And this was a brief overview of our experiences, and I'd love to tell you more later on.
Yeah, and we will talk some more later on, Nick, but it's mind-blowing. Frankly, both of these presentations so far have been pretty mind-blowing in terms of what this worldwide pandemic has done to us. So again, I'm going to introduce our third speaker, and and remind you, put questions in the chat. Feel free to stick questions in chat or Q&A. And also, in case you weren't here for our initial introductions, our final presenter is Dr. Deborah De Bruin from the University of Minnesota, going to talk to us about communications during this massive pandemic.
Thank you. I want to talk to you today about the importance of ethics support during public health emergencies, to introduce you to our process for ethics support in Minnesota, and to talk about its foundation in earlier ethics projects in the state, and then to reflect a bit on lessons learned during the COVID-19 pandemic. You will pick up on themes. I think Jonathan and I have shared a lot of common experience, as it turns out. Next slide, please. I have nothing to disclose, and I'm not going to talk about any off-label use or investigational use, but we will talk about developing ethics guidance for investigational meds. I do want to make clear that I do not lead the Minnesota COVID Ethics Collaborative on my own. I want to acknowledge and thank my co-lead, Professor Susan Wolf, who's also a faculty member at the University of Minnesota. I want to thank the members of MCEC and our partners who I'll introduce you to during this talk, and with whom we work very closely. Next slide, please. So why do we need ethics support during public health emergencies? As the Institute of Medicine explained in its Systems Framework for Crisis Standards of Care issued in 2012, public health disasters justify temporarily adjusting practice standards and or shifting the balance of ethical concerns to emphasize the needs of the community rather than the needs of individuals. What does this mean from an ethics point of view? Under normal circumstances, or as we might say under conventional standards of care, clinical ethics focuses directly on the needs and wishes of the individual patient. Care is to be provided to patients largely based on commitments to promote patient well-being and to respect patient autonomy. In reality, of course, those norms tend to guide care for more privileged patients because there are all sorts of challenges with respect to providing care for more disadvantaged patients. So sometimes that breaks down, but those are supposed to be our guiding values during normal times. In public health crises involving significant shortages of resources, public health and healthcare systems become overwhelmed, and the norms guiding care must shift to focus on community benefit rather than individual well-being or autonomy. That's really the morally appropriate perspective to take in these circumstances. Next slide, please. So that shift in perspective has profound implications. It can leave health professionals facing tremendous uncertainty about how to meet overwhelming need while maintaining their fundamental professional values. Focusing on the needs of the community may seem like a betrayal of the fundamental commitments of clinical ethics. This may result in tremendous moral distress. So to give just one illustration here, if you were fortunate enough to see the earlier events in this webinar series, Dr. Hagab's presentation on December 3rd on changes in visitation policies in this pandemic provides a really great illustration of this issue around moral distress. She spoke very powerfully about the distress experienced not only by patients and their loved ones, but also by healthcare providers as patients die without the support of their loved ones. She told the story of a provider who tried to comfort a frightened, dying patient, but then given the crushing need on the unit, the provider had to leave the patient to go and care for others, and the patient died alone. That's just one example of the moral distress felt by providers in this context. The shift in focus can also undermine public trust in professionals, in health systems, and in governmental agencies. And so ethics guidance designed specifically for these kinds of events is really critical. Next slide, please. So there were two projects devoted to developing ethics guidance for public health emergency response in Minnesota prior to the COVID-19 pandemic. I led or co-led both those projects. The first was the Minnesota Pandemic Ethics Project, and the central aim of that project was to develop rationing frameworks for an influenza pandemic. That guidance was issued in 2010. The The second project developed ethics guidance for crisis standards of care, and that guidance was issued in 2016. Both of these projects were conducted under contract with the Minnesota Department of Health, and MDH issued final guidance for both. The process for developing guidance in those projects involves significant stakeholder input and community engagement, and both of those projects recommended that a process for ethics support be implemented in public health emergencies. Next slide, please. So, at the start of the COVID-19 pandemic, I reached out to MDH and offered to help them develop such capacity. The State Healthcare Coordination Center and the Minnesota Hospital Association quickly joined the effort, and Professor Wolf and I began to work with those partners to build the team and to develop the process for ethics support. The Minnesota COVID Ethics Collaborative, or MCEC as we call it, now includes more than 70 members from organizations across the state, incorporating perspectives from ethics, law, public health, medicine, nursing, disaster planning, and other fields. Every major health system in the state offers expertise to the collaborative, along with experts on tribal health and from governmental agencies, nonprofits, and academia. MCEC also works closely with the statewide critical care work group as well. Next slide, please. So all of MCEC's guidance is grounded in the values identified as foundational in those earlier projects, and you can see those values here on the slide. We identified a fundamental commitment, this pursuit of the common good that you can see reflected on the slide, and then identified 3 equally important and overlapping ethical objectives that need to be balanced in the ethics guidance in the emergency response. So not only protecting the population's health, but also respecting individuals and groups and striving for fairness and protecting against systematic unfairness. Next slide, please. So I want to talk briefly about how MCEC works. We identify the need for guidance in a variety of ways. Sometimes MCEC members raise issues that make it clear that certain kinds of guidance is needed. Sometimes we get requests from the Minnesota Department of Health. Sometimes we have engagement from the statewide critical care work group. All of these kinds of inputs can give rise to the creation of new guidance. Once a need for guidance is identified, MCEC forms a subgroup, typically, to do the initial research and drafting of the guidance, and we invite subject matter experts to participate in these subgroups. So, for example, the subgroup that created guidance for the allocation of remdesivir included clinical experts, some of whom had been involved in remdesivir clinical trials. As we worked on guidance around allocation of convalescent plasma, our subgroup included specialists in transfusion medicine and leaders of blood banks. Once guidance is drafted in subgroups, it then undergoes review by the full MCEC in plenary session, and that feedback from those sessions goes back to the subgroup, and we engage in a process of revision and review until MCEC as a whole feels that the guidance is ready to be forwarded to MDH. Then MDH reviews the guidance along with its science advisory team. If they feel it needs further revision, it sends it back, and we revise until MDH feels that the guidance is ready to be issued, at which case MDH issues the guidance, publishes it to the MDH website, and sometimes disseminates it directly to relevant provider groups or other organizations as needed. Even then, once guidance is issued, when things change, guidance is reconsidered. So this really reflects some of the things that John was talking about in his talk. So for example, when the emergency use authorization for remdesivir was first issued, little data was available for which patients benefit most from remdesivir, which made decisions about how to prioritize among patients really difficult. Over time, the publication of clinical trial data shed light on that question, and so we modified the guidance accordingly, and so the whole cycle begins again. Next slide, please. Rather than go into the detail of different guidances, I just want to acknowledge that there are some overarching challenges. How do we support and protect patients when the focus shifts to the needs of the community? How do we support and protect clinicians who provide care in this context? And how do we support and protect at-risk populations? I think it's really important to understand that those three concerns can conflict. And so a lot of the ethics work is really about how to balance them. And given those conflicts, I think it really matters that the ethics framework has those three objectives and balances those three objectives, that we do not solely focus on reducing morbidity and mortality. And I'm happy to talk more in the discussion period about how to strike those sorts of balances. So this last slide, next slide, please. The last slide just gives you further information about MCEC. The first web address is the MDH website that contains our guidance. And then there are a couple of publications that have come out of the project. Really quickly, in terms of lessons learned, our experience in Minnesota really confirms for me just how important ethics support is, not just at the institutional level, but also at the level of the state. I want to say that when we originally issued the recommendations about ethics support, there was a lot of concern that was commonly expressed related to the lack of resources to provide such support. And by that, I mean lack of funds. And I will say that I've been really inspired during this time about how much time and energy and thoughtful engagement people are really volunteering to make this work. The second thing I'll say is that collaboration is really critical. We need input on where guidance is needed, on the content of the guidance, on how to operationalize the guidance. The third lesson is that those questions about operationalization are actually really critical. It makes all the difference. It's not enough to issue sort of high-level principles, because providers need to know how to apply guidance in real time. So we really have to think about those operational questions, and sometimes how you operationalize the guidance makes it more or less fair. And finally, as I've mentioned, the guidance documents really need to be considered living documents. Our understanding is constantly evolving, and we need to recognize that not only new information, but new realities on the ground can change the kind of guidance that would be appropriate. So that's it. Thank you very much, and I really look forward to the discussion.
Okay, so make it 3 mind-blowing presentations here. This is just fascinating. I guess I'll start with you, Deborah, since we're on you already. I jotted down this little observation that I wonder whether you have experience or knowledge to inform, and that is, you talked about shifting the focus from being a focus solely on the individual patient to being a more community or population-based focus. Is this single-minded focus, is this, do you think, something that's a uniquely or fairly uniquely U.S. perspective? As in, I wonder if my friends in South Africa or Brazil have the same perspective on being sort of single-mindedly focused on the individual.
Yes, so I think that there are different cultural influences on how we think about the ethical values that prevail during normal times. That's essentially what you're asking. I think that's true. Yes. Certainly in the U.S., I think in some other cultures, there is this real fundamental individualism that then gives rise to a kind of whiplash when you have to shift to a focus on communities. Whereas in more communitarian cultures, you might not have that same kind of dramatic shift. I think that's right.
I wondered about that. There was a comment in the chat, by the way, thank you for mentioning moral injury. this resonated with at least one member of our audience and probably more than one. Before I move on, one quick, could you give us an example? You showed us the cycle of area of concern that needed to run through the cycle. Can you give us an example of one that's arisen?
Of the kinds of overarching challenges, you mean?
Or of sort of the problem, your one slide where you showed us there would be a consultation, and then the consultation would move on and move around the circle. And I'm thinking these are challenges that must have arisen in maybe one location or another in Minnesota that are brought to the Ethics Collaborative.
So I'll give you a couple of examples.
Yeah, cool.
One is a case in which the statewide critical care group came to us because providers were really concerned early in the pandemic about provider safety in a context of inadequate PPE and an expectation on the part of patients that standard practices around CPR would continue, for example. And so the statewide critical care group came to us and said, can you help us think through those issues about how to appropriately balance provider safety and both patient autonomy and patient well-being. And so there we really partnered with them and had a lot of conversation with provider groups around the state to try to make sure that the guidance that we were reflecting didn't conflict with policies at particular institutions, but that really addressed the kinds of concerns that were arising in the context. Another example is an example that kind of connects, Steve, with what you were saying at the beginning in your pitch to get vaccinated. So we've been having a lot of conversations lately about questions about prioritization of essential workers and how you figure out at what point in the pandemic you enact what level of priority, right? So essential workers are a much broader group than just healthcare workers, but we're recognizing in our conversations that as much as we think that there's some argument for a priority for access to certain resources anyway, on the part of essential workers more generally, that right now we're at the point in the pandemic where there's such a strain on healthcare workforce that maybe even a greater priority for frontline healthcare workers would be called for. And this is one of those places where those concerns about operationalization really play a role in questions about how fair that guidance is. So we've been having really specific conversations about things like, what metrics do you use to determine when your workforce shortage is great enough that it warrants a higher priority for access to resources? And then how do you track that to make sure that when your workforce shortage is more resolved, that you can reduce that priority so that members of the general public then have greater access to resources? Those are the kinds of balances that you have to strike.
Exactly. Those are great examples. Thank you, Deborah. John, I got a question for you. You probably know that I serve on the NIH treatment guidelines panel, and that from the outset has been conceived as a living guideline so that it's updated about every 2 weeks. How do you make a decision in a fluid situation like this? When are we going to switch over so this is now posted online and we're continually updating, or when we don't do that?
Yeah, I mean, that's something actually we struggle with our regular guidelines, and it's really been, I think, magnified with COVID. I think that the living guideline model, it takes a lot of resources, right? And there's a lot of questions of, well, who does the updating and who does the monitoring and things like that. At CHEST, we're fortunate enough to have great membership, but also great volunteers. And so we, really have put it on the guideline panels, the chairs and the panelists, to really kind of come to us at what point they feel there's either enough new data to change the quality of evidence. So even if it's the same recommendation, but perhaps now there's a randomized control trial that really shows what we were recommending, or whether the recommendations become outdated. And that's actually become the case already with a couple of our documents that we're actively working on. So, we haven't had the resources to unfortunately be able to do every 2-3 weeks, but we've kind of, developed a model to say, well, when there's enough new data, now what point that is really there's no great measurement there to say, oh, is one RCT enough to say that we should read the guideline? And at what point, you make a change. It's sort of, honestly, it's an active discussion that we have ongoing with each of our documents.
Mm-hmm. Yeah, fascinating. Nick, a question for you. This pandemic, it's moving rapidly. There's all sorts of patients who need research. Is the pandemic more, in your mind, after your presentation, do you balance this more as a help or a hindrance to getting RCTs done?
I think there's more resources available now. And so I think it's getting research done. I do think there's a real concern. It's whether or not we're doing good research. I think in many cases we are, but I think that's where I think there's a concern. There's a lot of research being done, but are we, allocating those resources to the people that will accomplish their goals and the groups that will accomplish their goals? So I think, and there's no overarching body saying that this is what we should do and shouldn't do. So I think overall research has certainly accelerated in pace during COVID, but I think we have to be careful about disseminating things that may be less relevant or maybe even at times wrong.
Yeah, exactly. I'm going to go back to John. This is a question from the audience here that I'm going to rephrase a little bit. Should a guideline incorporate data that's from a preprint server and hasn't been peer reviewed yet, or not? And what is the impact of preprint servers on guidelines?
Yeah, so in general policy at CHEST, we do not include pre-published documents. That includes poster abstracts from conferences as well. That comes up with our regular guideline formation. But in terms of preprint, we don't typically, for that particular reason, they haven't really gone through peer review. And so the reliability of those studies and whether or not there'll be changes or significant biases made it clear, it just really hasn't happened yet. We don't typically do that. And I will say that, most of our panelists, we were fortunate that we have sort of experts in the field. And so their expertise and guidance often can guide us there too, where they say, if they say this is a really well done study, it should be published soon. Maybe we actually hold the guideline until we have a better indication of what the, publication status of that, if it's a major study. But we don't typically include those because they tend to be fraught with potential for bias. And as important as getting the guideline right is, you also have to worry about perception and faith in the guidelines. So how are people, it's great to make a good recommendation based on evidence, but we also want people to have faith in the process and to believe it. And I think that's why we hold it to such a high standard.
Yeah, exactly. Here's an interesting question that for Nick and Deborah, I think that has been fascinating to me. Nick, you mentioned that everyone wants to do research on these patients. And I find that everyone often includes people that have not been either pulmonary or critical care or infectious disease researchers who just have a pet idea and want in on it. How do you decide what's enough preclinical evidence that it's okay, we should let this person who's never had an interest in viruses or respiratory failure or lungs or anything? How do we decide who actually should be doing the research in a pandemic like this one?
Yeah, I think for us and others, there is an executive committee that helps to make these decisions and acts as a buffer to IRBs. I think that at the local level is a good model. Not everyone can do research, and you have to balance several factors: the risk benefit, whether the investigator can accomplish what they set out to accomplish, just like you would, I think, with a grant. You have to gauge those things. So I think at the local level, it comes a little bit more straightforward. I'm not sure we have a great answer for more broadly, other than it's, comes down to who gets funded.
Yeah. Deborah, do you think, does that pose any ethical issues when somebody who actually isn't an expert in this field thinks, hey, great opportunity, let's do this research now?
I think it definitely poses ethical issues, because you have to think about so many things. What is the value of the research, and is what we're going to learn from this research, is this a team and a study design that is going to teach us something that's important and relevant to help patients or to help guide care? And so is what we're going to learn and what we're going to learn reliably, does it justify the risk that we pose to patients in studies? And so, I think we have to think in terms of those kinds of, risk benefit trade-offs, where here it's not necessarily just a question about risks to study participants versus benefits to study participants, but risk to study participants versus benefits of the knowledge gained. And how do we assess that issue about the value of that knowledge gained is really centrally an ethics question.
Yeah, absolutely. Good. Thank you for that. Well, guys, we are at the top of the hour. And as much as I am loath to sign off with the three of you here for me to pick your brains, I'm afraid we're going to have to do that. I want to say thank you, deep thanks to all three of you for your participation here and for the knowledge that you brought in and the, I will say again, mind-blowing presentations, all three of them. I'm going to close for those of you who are on the line with a word from my boss. I work half-time in the Department of Health and Human Services in Washington, D.C., and my boss is the Assistant Secretary for Preparedness and Response, Dr. Bob Cadillac, who's a wonderful individual. And his admonition to us with every meeting is this: be positive, test negative. So with that, I will say thanks for being with us, and everyone have a great afternoon. So this is probably a good time for me to make a plug that I was going to make later in the show anyway, and that is the plug about getting your vaccination. Those of you who are on this webinar and who are members of CHEST, practicing pulmonary, critical care, and sleep physicians, are well aware that you're on the front lines and well aware that you are exposed to patients with active COVID-19 on a day in, day out basis. I will admit that, first, I hope I'm not preempting anything Dr. De Bruin, but I will admit that I had some of my own ethical dilemmas about receiving a vaccine before vulnerable patients. But I'm advocating now, after looking around and seeing how full the ICUs are and overflowing, and recognizing that without us being there on the front lines, that our patients don't have anyone to guide their care. So I think it is highly important that we get ourselves protected and keep ourselves from going down the pathway of the patients that we're caring for, because we can't help them otherwise. So I'm here to advocate for get in line, get your COVID-19 vaccine, and be around to take care of patients.